Everyone. I would like to thank Dr. Deepak for this opportunity and also the AOS Scientific Committee. First of all, we need to demystify and debunk the theory that we need high-end gadgets and equipments for the practice of toric IOL implantation in our cataract workflow. So let me begin my presentation. In my own personal journey, I had initially some overwhelming thoughts about the terms, the words which were used in the practice of toric IOL implantation, and I had my own kind of anxiety about using these toric IOLs in my cataract workflow. So, over a period of time, the confidence has built up. And as we see, the scale of the problem is almost 30% of the cataract patients who require surgery would require a toric IOL. This would mean every 2 to 3 patients out of 10 would require a toric IOL. This is justified by all the data and all the statistics which are obtained from all the journals. At least 30% of our workflow would require a toric IOL. Coming to the case, first case here, he is a 70-year-old man. He is scheduled for right eye cataract surgery. He has, against the rule, astigmatism. In this patient, we were able to do only two basic tests. Biometric values which were obtained are auto-K reading, which were repeatedly consistent, suggesting a cylinder of 0.75, axis of 106. We did not have optical biometry. We did an immersion scan. The immersion A scan also agreed, and the topography also agreed on the magnitude and the axis of the cylinder. So this is the patient who opted for a toric axis of IQ, and this is the final printout which the Alcon toric IOL calculator gave us. Patient required a T3 series of IOL, toric IOL at 10 degrees. So what I try to emphasize here is we didn't have optical biometry in this patient. We did not have any other ways of estimating the post-corneal astigmatism. Two simple tests which conversed on the biometric values, we were able to get a emetropia target of 6/6 in this patient. Coming to the next patient, here again, this is a 65-year-old lady. She has, against the rule, astigmatism of minus 1.5, axis at 87 degrees. And when we see, we obtained 4 important biometric measurements from auto-K reading, a topography scan, immersion scan, and also IL Master 700. This patient had chosen an Indian toric. They own these IOL manufacturers themselves have their own toric formulas, and finally we could obtain a toric lens which had to be implanted at steep axis of 174 degrees, and patient did well and obtained 6/6 vision. So, to conclude from these two case studies, we can now understand that against the rule astigmatism is the most commonest incidence, and also we did not have high-end equipments to do or incorporate toric IOL in our workflow. So coming to certain simple aspects of astigmatism or refreshing the astigmatism principles in our practice, we have regular astigmatism, which is the most common indication for using toric IOLs. Regular astigmatism can be with the rule or against the rule. In with the rule astigmatism, the steep axis is at 90 degrees. In against the rule astigmatism, the steep axis is at 180 degrees. Whenever we counsel patients for toric IOL implantation, there is a flexible plus or minus 30 degrees from the steep axis. As you can see, 60 to 120 degrees and 30 to 150 degrees. So plus or minus 30 degrees, we can still counsel the patient for a toric IOL implantation. So coming to the progression of astigmatism as we age, in infancy and childhood, it's usually with the rule or against the rule. In the middle age, it turns out to be with the rule astigmatism, and as we age beyond 50 years, generally it is against the rule astigmatism. Coming to the second important aspect of surgical induced astigmatism, astigmatism that is observed after routine phacosurgery, each surgeon has a surgical induced astigmatism. Over a period of a decade or so, it has been observed that it is based on the size of the incision, and generally when you are a temporal phacosurgeon using a 2.2 to 2.8 millimeter incision, you are inducing almost negligible astigmatism or around 0.1 diopter of astigmatism. So whenever the biometry online toric calculators use a assumed value of 0.1 diopter, it is because they have seen that these temporal phaco incisions are least astigmatic. So they are assuming that the astigmatism induced by these incisions is around 0.1 SIA. Of late, SIA has least importance in the workup. There are multiple websites and softwares available to calculate the surgical induced astigmatism. But what is important now is concept of the posterior corneal astigmatism. So here the total corneal astigmatism is the sum total of the anterior as well as the posterior corneal astigmatism. Sometimes the surgeons used to experience refractive surprises whenever they were not considering this posterior corneal astigmatism, and so they saw the role of the posterior cornea as a refracting surface. Anywhere around 0.3 diopters of against the rule astigmatism of a minus lens, meniscus lens, is assumed to be contributed by the posterior cornea. So as we can see here, when the biometric value of the K reading is obtained, when you see the K 1.09 plus 1.09 diopter at 171 degrees, but the total K is 1.45 diopters at 174 degrees. So 0.40 diopters would have been missed. This is contributed by the posterior corneal astigmatism. Devices which measure posterior corneal astigmatism are these, but it is not mandatory to have all these devices in your workflow. Workup of the patient includes a case selection, accurate biometry, and IL power calculation. Case selection includes ruling out pterygium, dry eye, and other aspects. Senile cataracts, usually more than 1 diopter, is the usual indication. In my practice, I would be low on my threshold for against the rule astigmatism. Usually 0.75 is the cutoff. With the rule astigmatism, 1.25 diopters or more. There are ever expanding list of indications, but most of the times for a beginner surgeon, stick to the conditions of simple cataract without any irregular corneal surface due to pterygium or any other ocular surface pathology like dry eye. Keratometry reading has to be taken multiple times so that we see that the multiple readings are concluding on the values. Coming to these formulas, these are excellent formulas, especially the Barrett toric calculator is an excellent formula. Suppose you would want to choose an Indian IOL, the Indian manufacturers themselves have their own online calculative devices through which they would be providing you the sheet for you implanting the IOL, including the access to be implanted. So we have Acreol and Biotech, I think. These are the companies where we do get IOLs from Indian companies. Let me rush through this video. So in a post-polar cataract, okay, yeah, finally. So a 4.5 millimeter excess is done here, and After the nucleus removal with the chip and flip technique, the cortex is removed. There is central plaque here. The manual marking of the axis is done in the slit lamp in this patient. The toric IOL, chosen IOL, is implanted in the axis. So, few years back, post-polar cataract was a relative contraindication for the implantation of the IOL, but of late, even in post-polar cataracts, we are able to implant toric IOLs. To conclude, for any beginner surgeon, we always have a mental block that machines are ahead of us, but it is the surgeon. We can work in conjunction with the machines, in tandem with the machines. We need not have high-end machines like topography, Shimflug, Pentacam and all. It is good that we have, because most of our panelists and here co-instructors do have, but for a beginner surgeon, a simple ultrasound biometry with multiple K readings which are consistent can also help in the beginning of the toric IOL implantation. With this,